Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Hello dear friends. Today we are learning surgery lecture number 11, that is the diseases of the gallbladder and the biliary system. In this lecture we learn anatomy of the biliary system, congenital anomalies of the gallbladder, duodenal cyst, congenital biliary atresia. All these points we will cover in this lecture number 11. Here in this diagram you can see the anatomy of the biliary system. There is a right hepatic and left hepatic, common hepatic, then cystic duct, common bile duct, duct of Wirsung, duodenal papilla, sphincter of Oddi. All these are seen on your screen. This is the anatomy of the biliary system. Now the functions of the gallbladder are storage of bile, concentration of bile, changing the reaction of the bile, that is the pH should be maintained 8.2 to 7, secretion of mucin and cholesterol excretion. These are the functions of the gallbladder. Now congenital anomalies. What are the congenital anomalies of the biliary system? First we see the gallbladder. Gallbladder have congenital anomalies like absence of gallbladder, that is the extremely rare, duplication of the gallbladder with two separated cystic ducts, Bilobed gallbladder with single cystic duct, accessory gallbladder, Phrygian cap of fundus detected in 5% of cholecystography, floating gallbladder. Gallbladder may be left-sided, that is the retro displacement. Gallbladder may be totally intrahepatic. These are the anomalies of the gallbladder. You can see on the screen normal, hypostatic, agenesis, Phrygian cap, diverticulum, like these anomalies of the gallbladder. Now here is another slide also of gallbladder anomalies, that is the absence of gallbladder, Phrygian cap 2 to 6%, floating gallbladder, double gallbladder, absence of cystic duct, low insertion of cystic duct, accessory cholecystohepatic duct, atresia, choledochal cyst. Now hepatic duct anomalies, accessory hepatic ducts 15% of cases contributes only, cystic ducts may be absent and gallbladder is joined to the common hepatic duct, cystic duct may be even longer and may join the common hepatic duct behind the duodenum. Cystic duct may be quite long and its union with common hepatic duct. Cystic duct may drain into the right hepatic duct. Cystic duct crosses anterior to the common hepatic duct and join its posteriorly. Cystic duct drain into the left or right hepatic duct. Here is in this diagram you can see how the cystic duct draining in the common bile duct. Now choledochal cyst. Choledochal cyst means the cyst of the common bile duct. Classification is like there is a type dilation of extrahepatic ducts, commonest and common as choledochal cyst. Type B is rare disorder. Cystic dilatation takes the form of diverticulum and is connected with a small stalk of hepatic duct, gallbladder or the common bile duct. Type C, choledococele, that is the cystic dilatation involving only intraduodenal portion of the CBD. This is the rare variety. Choledochal cyst, classified by Alonso Les, type A, is the most common variety of congenital cyst of the extrahepatic biliary tract. Now the diagram slide you can see on your screen that the choledochal cyst, first is seeing the normal, second is the CBD is dilated type 1, and there is a cyst in the CBD type 2, type 3, type 4 and type 5. Choledochal cyst, types of the choledochal cyst. Here is a clear diagram: solitary extrahepatic cyst, extrahepatic diverticulum, choledochal cyst, extra and intrahepatic cyst, multiple extrahepatic cyst and multiple intrahepatic cyst, that is the Carroll's disease. These are the types, diagram showing the types of the choledochal cyst. The three major varieties: cystic dilatation involving the entire CBD and common hepatic duct while the cystic duct entering the choledochal cyst. Second is the diffuse dilatation of the CBD, a small cystic dilatation of the distal CBD. Clinical features: occurs 4 times more frequently in females. Cyst may contain as much as 1 to 2 liters of bile and cyst wall shows inflammatory changes with absence of lining epithelium. Now classic triad of the symptoms of the choledochal cyst is upper abdominal pain, obstructive jaundice, fever due to cholangitis from bile stasis and bacterial colonization. Special investigations are intravenous cholangiography, USG, transhepatic cholangiography, MRCP, a popular investigation to diagnose the choledochal cyst. Complications: if untreated, this condition proves fatal, lead to complete biliary obstruction, ascending cholangitis, and secondary biliary cirrhosis if rupture leading to diffuse the peritonitis occurs frequently in pregnancy. Now the treatment. Early operation is the treatment of choice. Type A, excision of cyst coupled with Roux-en-Y, anastomosis of jejunum to the proximal normal duct known as hepatico-doco-jejunostomy. For type B and C, excision of the cyst followed by anastomosis, either choledoco-duodenostomy or choledoco-jejunostomy. Now congenital biliary atresia. What is the atresia? First, the concept regarding atresia should be clear. Atresia means absence or abnormal narrowing of an opening or passage in the body. Atresia means absence of a normal opening or failure of a structure to be tubular. Means it should be tubular, but in the atresia there is no continuity of tubularity. Atresia is a condition in which an orifice or passage in the body is usually abnormally closed or absent. Now the congenital biliary atresia, what is the pathology behind this? The bile ducts first develop as a solid structure. Gradually the solid core becomes vacuolated and the vacuoles collide to establish the lumen. Arrest in the solid stage causes biliary atresia. A, in 10% of cases, complete absence of all extrahepatic ducts. B, in 64%, partially obstruction, particularly the distal part, so that proximal part is dilated with sign of obstructive jaundice. C, type of biliary atresia, in 11%, total atresia of the hepatic ducts but associated with normal CBD. D, in 5% atresia of intrahepatic bile canaliculi and 7% have atresia of the visible larger intrahepatic ducts, that is the Caroli's disease. Next type of biliary atresia, rest of 3% demonstrate only stenosis. Now the image you are seeing on your screen, that is the biliary atresia. You can see how the lumen is narrowing on the various spot, that is due to the fibroinflammatory obstruction of extrahepatic bile ducts. Here is another image which showing the common hepatic, common bile duct and cystic duct are atresia. Here is a CBD or gallbladder atresia, type 1, type 2, type 3. Now the clinical features of atresia is jaundice, most common finding. Either it is present at birth or shortly thereafter. Jaundice usually does not become deep until the child is about 2 to 3 weeks old. Hemorrhage due to reduction in prothrombin time following vitamin K deficiency. After that, jaundice becomes gradually progressive. First, meconium is often normal. Thereafter, the stools are white or clay color. Petechiae or subcutaneous hemorrhage due to reduction in prothrombin time following vitamin K deficiency. If unrelieved, the patient usually die within 3 to 6 months. Neonatal jaundice may appear due to various medical diseases and these should be excluded. Now the special investigations. Which investigation is to be done in the biliary atresia? That is the blood examination which reveals excess bilirubin and mild anemia. HGOT goes up to 400 to 500. Urine examination will show excess bile pigments and no urobilinogen in the urine. Treatment: preoperative measures, vitamin K to combat prothrombin deficiency, broad spectrum antibiotics, choledoco-duodenostomy and choledoco-jejunostomy or hepatico-doco-jejunostomy should be performed according to the circumstances. Another indications like straight X-ray of the abdomen. These are diagnosed radio-opaque stones in 15% of cases. Oral cholecystography to visualize gallbladder by using contrast medium, first introduced by the Graham and Cole in 1924. Successfully visualization of gallbladder depends on blood flow of the liver, ability of the liver cells to excrete the dye into the bile, patency of hepatic and cystic duct system, and capability of gallbladder to concentrate the excreted dye. Contraindicated. This procedure of dye is contraindicated in acute cholecystitis, in jaundice, renal function impaired, teleopaque, most common contrast medium in the lab which is commonly used. Third is the intravenous cholangiography, applied when patients are unfit to absorb the orally administration of contrast medium, probably suitable for visualization of the bile duct, particularly after the cholecystectomy. Now the technique of this procedure: 20 ml of bilographin is injected slowly over 3 minutes. Very soon contrast medium appears in the bile with the concentration of 15 to 100 times that of the blood. This causes radiological of the biliary tract. Disadvantages may cause severe allergic reaction, cyanosis, stertorous respiration, imperceptible pulse. Radionuclide scans are gradually replacing this technique. Fourth investigation is the operative cholangiography. Contrast eye is directly instilled into the cystic duct during operation to demonstrate the entire biliary tract. Fine polythene catheter is passed through the cystic duct into the common bile duct. 25% of Hepatic or urographine is pushed through the catheter and X-ray exposures are to be taken. Indications: know the congenital abnormalities of the cystic duct, hepatic ducts and the CBD. To detect the stone in the biliary tract, particularly in CBD, to know whether exploration of bile duct is necessary or not. This prevents morbidity due to many unnecessary exploration of the CBD. Fifth investigation is the post-operative cholangiography. Performed after 10 to 14 days of the choledochostomy through T-tube, which was inserted into the bile duct during the choledochostomy prior to the removal of the T-tube to demonstrate patency of the CBD, presence or absence of retained stone, whether there is a free passage of bile into the duodenum or not. 10 to 15 ml per 50% of Hepatic is diluted with normal saline to 30 ml and this administered slowly through the T-tube. Sixth investigation is ultrasonography. Primary method of gallstone detection. This is the primary method to detect the gallbladder stone. Increase in the density of bile increases its echogenicity and reports of sludge within the gallbladder or CBD lumen may be detected. Next investigation is CT scan. Non-invasive technique, also helpful in diagnosing biliary calculi, useful for those patients in whom ultrasonography is difficult, that is the obese patient and with excessive bowel gas. Next investigation is radioisotope scanning, that is the cholecystography. Few isotopes have been used which are secreted in the bile and can define gallbladder function and its pathology. Nowadays, technetium IDA, that is the aminodiacetic acid scan, is most oftenly used. Gamma emitting agent, half-life of 6 hours it have. Diagnostic choice is acute cholecystitis. In acute cholecystitis, the gallbladder is not seen. Complete obstruction of CBD, common bile duct or the common hepatic duct is detectable on technetium IDA scan. Next investigation is radiomanometry. For the bile duct pressure can be measured to measure the bile duct pressure. Next investigation is choledocoscopy. A choledocoscope inserted into the supraduodenal part of the CBD to determine presence or absence of the calculi there. Technique may be used when the CBD is explored, used for removal of the stone and bile duct tumor and for biopsy. PTC, percutaneous transhepatic cholangiography. With a 23 gauge thin walled needle, 45% Hepatic, 20 to 40 ml is injected and X-ray exposure are made. Next investigation is endoscopic, that is the ERCP, endoscopic retrograde cholangiopancreatography. CBD and pancreatic ducts can be cannulated by side viewing fiber optic duodenoscope through ampulla of Vater. Polythene cannula with 60% of urographine, 25% of Hepatic is used. Indication for ERCP is jaundice, obstructive jaundice, biliary tract problem and pancreatic diseases. Complication of the ERCP is most likely infections, that is cholangitis and hepatitis and pancreatitis. This is the cholangiography you have seen on your screen. The biliary tract is clearly seen. There is obstruction. This is the another image of biliary atresia and obstruction in the biliary tree. This is the ERCP side view camera in duodenoscope. The same image, same procedure by the side view camera of the gastroscope, which is cannulated through the ampulla of Vater in the CBD. Endoscopic retrograde cholangiopancreatography means ERCP. Okay, here is the end of our surgery lecture number 11. Thank you.